affected by external factors. So if the Durex condom market share is not growing, it's going to be hard for us to increase use of condoms that are not our market share. So if we're increasing condom use and we're the sole provider there, we're not going to get BCC Dallies for it. Similar with other products, if the public sector's MC services are not successful, there's not really much that we can do beyond trying to promote them as much as we can.
Yeah. Market share is an important one. I mean, as we said, that these BCC Dallies are the additive Dallies. They're the Dallies that we avert for promoting or helping people use products that are not our own. So if we have a significant proportion of the market, you know, our Dallies are limited. Anything else? Anything else? Yes.
Limitations perhaps in measuring the BCC Dallies from our own interventions.
What do you mean specifically?
Well, having to do track studies and yeah.
Yeah, limitations with measurement and how we're measuring this. Yeah. Anything else that might? Yes.
Is it hard for us to get the information on these, you know, like from Durex, let's say, about what exactly is going on, how many condoms are being sold, or from the Ministry of Health? Can we always get that information from them?
Well, I know there's discussion about how reliable is market share data, if that's kind of what your question is, and I think you guys know more about the reliability. We have estimates that we have estimates of our own market share as indicated in the health impact report, but
when we collect data, we suggest some questions to be collected, to be asked. Like for example, the condom use, we ask the interviewee how many times do you use condom, and then among these condoms, how many of them are PSI? No, not PSI. These branded condoms. Okay. Yeah, so we can show them pictures, so to have them recall, and we can show the pictures of PSI branded condoms. So from there we figure out the market share of PSI condoms and also the market share of non-PSI condoms.
So there's some estimate based on self-report, but there also could be some other estimate or data about, you know, what is kind of what a vendor may report. But I think we do rely heavily on the track and the self-report and what condoms people report using. Anything else? Okay, so this was already brought up or introduced in the beginning. Again, the reason that we're doing this, there have been a lot of discussions around BCC Dallies and the strategic plan. And I just went back through a series of emails that were exchanged probably 2 weeks ago. And in my estimation, the concerns and the discussions around BCC Dallies fall into 3 different buckets. One is, somebody brought this up earlier, do our BCC interventions really suck? Quite frankly. I mean, are we really that bad? And maybe that is a factor. In fact, in some places, you know, many of us will say they're bad. 2, I think this was also brought up, was this 2 million target evidence-based? So again, and this is the question we're asking throughout this, if we're doing so poorly, was the target just so off that we could have never achieved it? And the third was the question that was also brought up, is the measure and are the inputs of the metric off, or hard to achieve, hard to measure, hard to quantify? So before this whole discussion started, before it reached a crescendo, I think, within the past couple of weeks, we, metrics in the HIV department, were working on trying to document countries that had programs that had averted BCC Dallies for the purposes of trying to increase people's level of understanding around BCC Dallies. And ideally, we envisioned that the audience for these case studies, which were the documents, would be program managers at interfield programs, and also research teams, but all of us as well, so that we could increase our understanding. There's been a lot of shouting and attacking of the BCC Dally, but a lot of it has been based on a limited understanding of what actually a BCC Dally is and what the inputs are to the metric. So our idea was, let's really try to get some basic understanding of what this is using case studies from the programs that have actually averted BCC Dallies, the good and the not so good. So we know that there's a wide range of number of BCC Dallies averted, and we've heard some of our more vocal colleagues in the field voicing their opinions about the number of dallies that have been averted. So, but those stories, no matter if they're huge numbers of dallies and it's all relative, or very small, they tell us a story, and they have actually told us a story. So as we move forward with finishing these case studies, we've also kind of realized through this process that this gave us a lot of information to help us kind of improve and hopefully inform the strategic plan as we move forward. So we picked 3 countries, and these, I'm going to go through kind of snapshots of these case studies. One of them has been complete. The other 2 will be finalized shortly. So the first one was India. So we're probably all somewhat, or many of us are familiar with India's Avahan program. The precursor to Avahan was Operation Lighthouse, OPL. Both of them have been fairly documented internally, but we could certainly document them more. During the period 2006 and 2008, and that's bookmarked by when the baseline track was conducted and when the round 2 track was conducted, the India Avahan program was able to document averted BCC DALIs. When we talked to the program team, they thought that there were 2 key elements to their intervention that were crucial to the number of DALIs that they were able to avert. The program, and I should say this first, targeted male clients of female sex workers. And for those who know about it, it's a highly targeted kind of IPC-driven intervention. India is obviously unique. There are billion people in India, and you can very quickly get to a high number of people or reach a high number of people. But they did focus the intervention on specific hotspots in 4 states in India. Hotspots meaning places where they could easily have access to male clients of female sex workers. And again, as I mentioned, they focused largely on studio theater performances with other IPC activities. The other thing that they felt was really, really important to their intervention, and this